Hello, everyone. In this lecture, I'll be going over how to use research for assessment as a therapist. We'll start with discussing the purpose of assessment. So in research and in the studies that you'll read for this class, you'll see assessments, typically self-report measures, used as a means of tracking efficacy of interventions and treatment. As clinicians, the focus here is twofold. First off, we're wanting to establish a baseline of functioning that will be useful for diagnosis and goal setting. The assessment that we complete will provide us with a starting point to see how things progress during treatment. Next, we also want to be monitoring progress and potentially to see if our client is one of the ones who doesn't benefit from a specific intervention that we've selected, despite what the research is saying. Once we have a baseline, we begin offering the treatment and monitor change using the same assessment tool in order to see if it's working. For example, you would provide a self-report measure such as the Beck Depression Inventory at the beginning of treatment, then provide some treatment and re-administer the BDI, the Beck Depression Inventory, again to see if the scores have changed. This would be similar to how we ask our clients to rate a certain behavior when developing treatment goals and to select a level to then become the aim of treatment. So they may want to reduce their depressive symptoms, for example, from 10 times a week to 7 times a week. Okay. Now, there are lots of different ways to do assessment. Okay. And the first thing that you'll need to figure out is what exactly to assess. And you're wanting to basically translate the topic of interest or your target problem into observable terms, sometimes called an operational definition. For example, if you're interested in studying depression, you would need to quantify it. What does that depression look like that you're studying? You could use a general measure to find out what the predominant symptoms are in your client, or you could use a depression-specific measure to see which types of symptoms of depression your client is experiencing. It is possible that your client with depression has more of the classic symptoms of depression, isolation, low energy, and so on. Or maybe they have a different type of manifestation of depression, and you're going to want to figure out what exactly is going on for them. You should also consider which client characteristics should you be thinking about when you're assessing. You want to make sure that the assessment that you select is feasible and appropriate for your particular client. It would not be appropriate to provide a predominantly Spanish-speaking client a measure that's never been translated into Spanish, for example. And it might not be feasible to provide this amazing assessment of anxiety if you have to pay $300 to access or score it, unless your agency is going to pay for it, which is unlikely. The next thing to figure out is who should be doing the measuring. There are 3 or 4 different things that you can think about, or 3 different options, that you can think about in terms of who's providing the information or who's gathering the information. The first and most commonly used is the therapist. Okay, this is the most commonly used form of assessment and is basically what you're doing when you complete a mental health intake, or if you work for the Department of Mental Health, an initial assessment or IA. You can see part of the adult full assessment attached here on this slide. There are benefits associated with doing an interview. First off, you as the therapist have the strong knowledge of diagnoses, predominant presentations, you know what to ask for, how to ask for it, and you have your clinical judgment to inform the direction of that interview to make sure you get all relevant data. Of course, there are limitations to having the therapist be the one who is gathering information. First off, measurement and assessment can only occur with you being present. So you're limited to the amount of assessment time you have with the client. And now that we've moved toward a more rapid-paced assessment process, you may only have maybe 2 sessions to gather all of this information before you're already expected to complete a treatment plan. And so that's a big limitation. Another issue is that you can only observe certain periods of behavior, meaning when they're in the office with you. And the way they present in the office may be different than the way they act at work, at school, at home, and so on. The exception to this is if you're in a group a group home or residential setting where you can see the child in their living environment, right? But this is a bit more of a specific case. Finally, your observation can feel obtrusive to the client and it can take a long time. You're asking a lot of very personal questions to someone that you likely just met. So they may feel uncomfortable sharing some information with you, and you might not really get as reliable of information as you'd like for assessment purposes. So a second option is to have the client be the one providing the information and completing the assessment. And when we're talking about the client gathering or reporting their own information, the most common way this is done is through a self-report measure or a behavioral measure. And these are things that you will learn a lot about in your assessment class if you haven't already. It can also be done by using things like journals, thought logs, and so on, which are also other ways that the client can provide information or do assessment of their own functioning. Okay, and that would be called record keeping. We'll go into this a bit more a little later. Some advantages: the client might be the only one who can complete this piece of the assessment or who can provide the information. Think about if you're measuring like feelings, right? Other than talking about the feeling, the client can't really portray that information to you outside of writing it out themselves, right? In like a journal or a diary. Or think about something that's more of a sensitive or quote private topic that they might not feel comfortable talking to you about in an interview. Like if you're asking them about their experience of trauma before they've really gotten to know you, perhaps completing a trauma questionnaire to screen for different kinds of trauma might be more helpful. Another benefit to having the client complete the assessment is that it can build self-awareness. It can help the client to get some insight into what is going on for them and how they are functioning. It's also less work for you because the client is the one providing the information and filling it out, and it may be less intrusive. Limitations: you are relying on the client to follow through in this case, and they might not do so consistently or appropriately. Maybe they're going to score everything as the highest thing or everything as the lowest thing, right? And that's not necessarily going to be very helpful. They may want to appear more or less impaired than they actually are, and so that might skew what they report in their assessment. A third option is to have a third party give you assessment data. And this could be getting data from a parent, a teacher, if your client's a child, a former therapist, a doctor, and so on. And this is done through like a release of records in the case of doctors and former therapists, or through report measures that are parent report or teacher report rather than self-report. There are some clear advantages here. Again, it's less work for you. This also works for clients who are severely impaired or very young and wouldn't be able to provide you reliable data in a self-report measure. It again is less obtrusive because it doesn't involve asking the clients questions themselves, someone else is doing it. It also doesn't make the client repeat stories that they have likely answered before. And it allows for holistic treatment and continuity of care since you can access information about previous treatments from therapists or doctors. Of course, there are disadvantages. The third party might not follow through, just in the same way the client might not follow through. If you're having them do an observation, like with a teacher, they might not complete the observation correctly, or their bias could affect their measurement. And finally, the client themselves may not be comfortable with having someone else provide that information to you, or having someone else even know that they're in treatment, which would limit the possibilities of third parties that you could get data from. A final way, and I don't have it in here, but a final way that you can get information is to use available records. And this would include things like adoption records or DCFS records, right? And so you get a release of information to gather those records. Advantages: this is completely unobtrusive. You're just getting paperwork and reading through it. It's feasible to do in most cases. It gives you a lot of data, and it's not limited to someone's perspective as much. Obviously, whoever created the data may have some bias, but this tends to be a bit more objective. Limitations: the records might not exist. You might not be able to access them. You are very limited in terms of what kind of information is there, and you can't really ask or find out more unless you come back to the client and do so. Okay. So when figuring out who to get the assessment data from and how to go about doing it, you want to consult the research to see which source or sources have been shown to be the most helpful and reliable. You might also consider if your agency has its own policies about the sources of data you can use. For example, most DMH contracted sites will require you to complete a mental health interview like the adult full assessment. And if you're doing some kind of specific program like MAP, which I've spoken about in the past, they're going to require you to use certain self-report and parent report measures. So you do want to defer to your agency as well. So let's think of an example here. which assessment tool might you use for our client Miguel, right? So remember, our client Miguel is a young child, 9 years old, who likely has experienced some trauma, right? Or not who likely has, who has experienced some trauma. And so you probably have already figured out that it's best to gather assessment data from Miguel, the child, from a source at home, a parent or caregiver, and in our case, probably his mother, since we know that his mother is the one who brought him into therapy, and a source at school. So his teacher, right? Because his teacher is the one that made the referral in the first place, right? The research would also show and support this approach. It would show that it's best to use a combination of child, parent, caregiver, and teacher when gathering data for a child, right? The research would also show that it's best to use a combination of mental health interview, which you, the therapist, would do, self-report measures, which would the child would do, and there are trauma measures for someone at the age of 9 to complete, and we'll talk about those later, and third-party measures, parent report, teacher report, and finally, observation. So if possible, for you to go into the school or into the home and conduct an observation and get data that way. Okay, so it would be, the research would suggest that a combination of all of those would be ideal and would give you the most holistic picture of what's going on for this child and inform your assessment and subsequent treatment the best, okay? Now, in the next slides, we're gonna go over different options for each of these and other potential tools that you might use, okay? So first, the mental health interview, and I've talked about this a little bit already. So you have the DMH initial assessment, which is an 7 to 10 page document, depending on if you're using the adult version or the child version, that guides you through conducting an interview to get data about functional impairments, functioning in various different domains of life, symptoms, mental status, family history, trauma, everything you can think of essentially, and can guide you for that interview. If you are at a DMH contracted site, this is the one that you'll use. And if you haven't already taken assessment, you're going to learn all about how to complete this in that class. Another option, if you're not at a DMH contracted site, would be what's called the integral intake, which you can see at the bottom of the screen. And that one is a longer version that is also used to complete your mental health interview. But what's nice about it is it gives you the exact questions to ask. And then another option would be the structured clinical interview, which is abbreviated the SCID, SCID, which is focused more so on diagnosing, but still provides you some useful information. So these would be your options for an assessment, for an interview assessment. Next, we have a couple of different self-report or third-party report things you could do. Two that I'm showing you here are behavioral recording forms and individualized rating scales, and I'll go through each one. So with behavioral recording forms, which is the one on the left here, the ADHD rating scale, this is doing either a frequency recording or a duration recording. So a frequency recording would be tracking the number of times a target behavior occurs. For example, you might want to know how many times does a child tantrum in a given week. Okay, and so you would have the individual track how many times. You can also do duration recording, which tracks how long the target behavior lasts each time it occurs. So this would be like the duration of the tantrum. Is it 5 minutes? Is it half an hour? Is it an hour? Is it all day? And so those are two different kinds of behavioral recording forms that you could have. In the case of a child, you could have a parent or a teacher complete, or in the case of an adult, you may have the adult complete it. In either case, you want to keep the form simple and teach the client or whoever is going to be filling it out exactly what they're observing. Instead of saying, write down how many tantrums you have, you would want to describe what that tantrum looks like. So each observer is tracking the same thing. And this helps to make this behavioral recording form really specific to the specific client. A tantrum for one client may be throwing things, whereas a tantrum for another may be isolating in their room, right? So you want to clarify that. Now, individualized rating scales are useful when ranking the magnitude or intensity of a target behavior or symptom. For example, ranking anxiety levels. You may have a client rank how anxious they are on a scale from 0 to 5, okay? And you can see on the right here, I'm going to move my face, a sample of an emotion thermometer that could be useful for children. And it has a ranking there of 0 to 5, but then allows the child to fill in words associated with each of those. So in this case, a 1 is calm for this child, whereas a 5 is furious. And then they can also make that observable by listing specific behaviors. So what does it look like for that child when they're calm? Are they resting? Are they sitting quietly? Are they smiling, right? Versus what does it look like when they're furious? And then you would have the child select where they are every time they meet with you in session and keep a track of that, okay? You want to keep these scales between 5 to 7 rankings at the most. Beyond that, it just gets to be too much. And for children in particular, or individuals of lower functioning, you want to add some graphics if possible. So you may have seen like the smiley faces, right? Or even take pictures if you have a permission from your client of your client making those faces associated with those particular feelings, right? And you would then determine how often to use this rating scale. Is it going to be done at every session? Is it going to be done weekly? Is it going to be done a few times a day? You'd figure that out with them. Okay, so those are behavioral recording forms and individualized rating scales. And you can find research showing which of these would be the most helpful for addressing or assessing your particular target problem for this class. Next, we have standardized scales. And these are the scales that you'll be most interested in for your project in this class. You'll want to find, as part of your paper, 1 or more standardized scales to measure or assess the mental health issue that you've selected. And what makes these scales standardized is that they've had their reliability and validity tested so that you can compare your client's scores to averages or norms more reliably and determine the functioning level of your participant. For example, the PHQ-9, which is here on the left, the Patient Health Questionnaire 9, has only 9 questions. And in addition to giving you an idea of what the client's predominant symptoms are, low energy, feeling down, etc., they also provide you with a cutoff so that if a client scores at that cutoff or higher, they are then thought to likely have, because you can't be definitive with these, a depressive disorder. Okay, and so that's a good indication to you that this person has a depressive disorder and it supports that diagnosis. But remember that this is not a substitute for your own clinical judgment and your own assessment. You can't just say, just because this said they're depressed, then I'm going to give them major depressive disorder as a diagnosis. You would still have to assess yourself. Okay. Another example is here at the bottom, the generalized anxiety disorder, the GAD-7. As you may have guessed, 7 questions assessing anxiety. So these are typically administered at specific times of the therapeutic relationship, usually at intake, midpoint, and termination. But in some cases, you'll use them on a weekly basis to track symptoms as long as they're not long. Like these would be appropriate to do weekly, but if you're looking at a longer scale, usually the ones that screen more generally, like the Youth Outcome Questionnaire, for example, those are much lengthier. They can be up to like 60 to 100 questions, and that would be extremely tedious to do every single week. So you wouldn't do that. But these smaller ones are okay. And so you can use symptom-specific forms like the BDI or the GAD-7 or the PHQ-9, or you can use those more general forms. Okay. And I'm going to be focusing in next on these standardized measures to help guide you in selecting 1 or more to use when studying your topic in this class. So we're going to focus in on this. Okay, so in addition to any other evidence-based assessment techniques or tools that you locate for your topic when you're doing your research, you'll need to include, as I mentioned, at least 1 standardized measure. You can locate these measures by looking at studies that include your identified topic as one of their variables. So for example, if your topic is depression in adolescent females and you type that into your search engine, and you'll find some articles, then you'll pull up an article that addresses that issue. And you're going to look for the scale that they have used, okay? So you pull up the article, and then you're going to go to their methods section, okay? And you're going to see how they measured that particular issue. So in this case, how did they measure depression? Did they use the PHQ-9, right? Or did they use something else? In that same section, in that same methods section where it says the variable names and how they were assessed, if they have a survey or a self-report measure that they used, they're also going to include a citation for the original creators of that survey. Who are the authors that created and tested that survey for the very first time? Okay, they also will often include some information about populations that this survey or self-report measure has been used with and other studies that have used it. Okay, so now once you have this, you will go and find that original study, the study of the original creators of the survey, and get more details about it. This is going to provide you with sample questions, how many questions, who it's been used with, what the reliability scores are, all of that useful information. From that, you would determine if this is something that's appropriate for your topic of interest. And next, if it's appropriate for your client in particular. Okay, again, if this scale has only been used with females and your client is a male, this is probably not the one that you're going to want to use. You're going to have to keep looking. Okay, does the scale avoid problems in language and interpretation so that it has the same meaning when administered to members of different cultures? Has it been translated into the language that your client speaks, and has it been translated well? Okay. Has it been used among populations similar to your client in terms of age and race ethnicity? If this is an adult scale, has it been not translated, but modified to be appropriate for children if your client's a child? If it's a measure that was developed for active duty military, has it been adjusted for non-military folks, right? Is it going to be appropriate? And some of them have been. Okay, so those are things to consider. So I'm going to recap that really quickly. You want to look for a study that includes the topic of interest that you have, okay? Go to the methods section and see where it says that particular issue, say depression, and how they measured it. And it will say depression was assessed using the PHQ-9, for example, and it will include in that a citation in parentheses of who the authors are or the creators are of that particular survey. You will then go and find that article where it discusses the creation and use of that survey, okay? And you will then check to see, is that survey appropriate, that self-report measure, is it appropriate for assessing your particular issue? Does it actually assess depression? And is it appropriate for your particular client? Meaning it's been used with other folks that are similar to your client, okay? All right. Here's an example, okay? For our client Miguel, we would consider using one of these measures, okay? And so I went and looked at a survey that looked at, an article that looked at trauma in children. And these are the two measures that were used, the Child's Behavior Checklist and the Trauma Symptoms Checklist for young children, okay? First, the CBCL is designed for parents to complete it and is used for children between the ages of 6 and 18. It provides you with information about 8 different symptom clusters, including depression, rule-breaking behaviors, aggressive behaviors, and others. It also has options for multicultural norms in order for the scores to be scaled and displayed in relation to different sets of cultural or societal norms. So this would be an example of using a general measure as opposed to a trauma-specific measure that a parent can complete about their child, and it's appropriate for children ages 6 to 18, okay? And it's going to give me an idea of what the predominant symptoms are that Miguel is experiencing that his mother has noticed, okay? So here I'm using a third party to complete a self-report, parent report measure, okay? I could also use, as I mentioned, the TSCYC. Sorry, I said that wrong. No, I did TSCYC. I just have the wrong acronym there. Okay. And this one is a fully standardized and normed measure for children who've been exposed to trauma. So this one is specific to children who've been exposed to trauma. So I know it's going to be appropriate for children. Okay. I want to get more specific and see what about 9-year-old children in particular. And yes, indeed, it does contain a separate norm for 5 to 9-year-olds. So it breaks it down by age, which is great. The other thing that this checklist includes is a separate norm for males and females. So I know that it's been tested with boys and I could use it for Miguel, okay? This one is to be completed for caregivers, which is appropriate, in this case, the parent. And it's available and tested in Spanish, which is wonderful if it turns out that Miguel's mother prefers Spanish, okay? So if I were to select to use both of these, I would write up my rationale with relevant citations for this selection in the assessment section of my paper for this class. This would include a little information about the measure itself, so some sample questions, okay? Why it appears appropriate and could be helpful, because it's screening for trauma, because it's appropriate for children, because it's going to give me a general idea of what's going on for me again, for example. Who it's been tested with, children, boys, children with trauma, okay? Who would complete the measure? In both of these cases, the parent, okay? And what the scores would mean. So I would look at the interpretation of the scores and explain, okay, if the score ended up being such and such score, this would suggest this, okay? That perhaps the client may have PTSD, and that would be for the TSCYC, okay? And so that's what you would be doing, all right? During our class time this week, you're actually going to have an opportunity to locate and evaluate the appropriateness of a standardized scale for your particular topic. So if this is feeling a bit confusing or you're not sure where to start, that is totally okay. In class, I'll guide you through it. And the goal is at the end of class that you will have the measure that you'll be using for your paper in this class, okay? So thank you. I look forward to discussing more with you. Let me know if you have questions. Remember, you can always post on the question discussion board. And I will see you in class.